My name is Tony Lai. I'm an interventional cardiologist at John Flynn Hospital. I've been practicing here since 2012. John Flynn currently performs TAVI usually 2 to 3 times a month by different operators, probably 5 to 10 TAVI procedures a month. It is a very special occasion that we have performed 250 TAVI procedures at John Flynn Hospital because it's a cutting-edge procedure that we are now able to provide people with severe aortic stenosis with the least minimum invasive procedure that is safe, that is as effective as surgical operation, and most importantly, we can improve their quality of life after the procedure.
Well, first of all, a physical examination will give us a clue as to it is aortic stenosis or not. But apart from physical examination, an echocardiogram is a very important tool to diagnose the aortic stenosis, because we can actually see what the valve is doing, and also we can get some additional information from the Doppler to determine the severity of the aortic valve.
Most of the time, immediately we may see vascular complications or cardiac or the non-cardiac complications, but again, it is rare. The cardiac complications such as the dislodgement of the valve or the valve being placed in the wrong positions, and the scenario where stroke can also happen on the table, but again considered rare.
Now we can treat these patients. So anybody who has severe aortic stenosis and wants to have a better quality of life and improve their survival.
My name is Joy Carr and I'm 88. I used to go out with my girlfriends a couple of times a week for lunch. I've done that for years, and I love to get, because I've always loved clothes, so I love to get into the clothes shops. Well, I haven't done that for quite a while. It's such an effort to go out when you've got this on your chest, and I think it was the doctor when he did something, because I didn't really notice till lately. I have, though, because I had this no pain. It's like a pressure on your chest. Goes look halfway down nearly to your navel, just like something, oh. Well, I've had that for probably 6 to 8 weeks. It's just got like that. And my breathing's a bit, I have to take a breath. And having to lean on someone to walk, you're weaker. I'm not saying it's agony or anything. It's just this bad pressure.
Most of the patients with severe aortic stenosis, they present with symptoms of heart failure, such as they can't breathe, they may have chest pain, they may feel dizzy, and frequently they may also have syncope, meaning that they lose their consciousness.
I was unlucky, but it hasn't spoiled my life. And I'll get this operation, and I'll go in there smiling. I talk to the doctor. They have to tell me to shut up. And I'll get that done. I'll be as good as gold. We're living in a wonderful time to have this done. As I say, all my father's family are gone. Yeah. I mean, they'd be dead anyway now. It's a few years back, but they all died of this one thing. A lot of people think they're too old, but look what I told you. I'm 88. The next one, all in the one day, 87. Another one, 86, that he's doing on the first up, because I'm the oldest. So that shows you people are living longer, and there's something that can be done. So don't ever say, oh, I'll put up with that or do something. You've got to be a bit serious, and I suppose I'm not that serious, but I'm not stupid neither.
They think that they're just getting old, but not necessarily the case. It can just present itself as shortness of breath, or sometimes you just feel tired and lethargic. And most people tend to think, oh, they're just getting old, so it's time to slow down. But that may not be the case. And once we actually recognize that the symptoms are due to aortic stenosis and end up fixing the problem, then that's when they realize that how good they should be feeling, and not that they were getting old.
My doctors, the ones I've had, they always explain things to me, and Guy did too. He explained everything. This is where it's good having a doctor that you can talk to, I think I embarrass him a bit. This is lovely here, though. Everyone's lovely. In fact, it's like I'm on a resort, really. Yeah, when I came in, I thought, oh, this is good. I wouldn't mind a few days of this, you know. And no, it's a lovely hospital. Lovely, caring. Nurses couldn't be better. But no, I'm not worried in one little bit.
Once the severe aortic stenosis has been confirmed and then it's been deemed a probable suitable candidates for TAVI procedure, then they will go through a vigorous series of investigations such as checking their coronary artery status with coronary angiography, and we'll be doing an echocardiography again to assess the hemodynamics of the severe aortic stenosis. They need to have their peripheral artery checked to make sure that their peripheral arteries are big enough to have a valve going through their femoral artery. And once all these investigations are performed, they usually go through another check with other geriatrician or rehab physician to making sure that they are suitable from a functional point of view, making sure that they are cognitively suitable for the procedure.
So each cath lab has a control room. This is the control room for lab 3. So in this room itself, this is where our radiographer sits. So all of this equipment is your X-ray machine equipment. So this is where they will manoeuvre the equipment from in here. They only have to go in if it's a particular angle or you have to manually move the machine around, but normally we can do everything from in here, which is fantastic. Then we have our monitor nurse who will sit here. So for each procedure, we have a scrub nurse, a scout nurse, and a monitor nurse. The person who's on the monitor is responsible for the hemodynamics and keeping track of the case log. So this is your legal document at the end of the procedure that states everything that's occurred during the case, and that's all logged into our macro system. And they also keep an eye on our ECG tracing, blood pressure, heart rate, if we don't have an anaesthetist. So most of our cases we don't, only TAVRs and the odd vascular case will have an anaesthetist, and majority of the time it's mainly the monitor nurse who's keeping an eye on that.
Oh, hi, yeah, Dr. Guy Rice-Smith. I'm an interventional cardiologist here at the John Flynn Hospital. I've been here for over 20 years now, 21, and we've been doing these valves here now for about 4 years. TAVI or TAVR is a transcutaneous aortic valve replacement, and it's for people who are not suitable to have an open operation. We access through the groin and put a valve in whilst they're awake. They stay in hospital for 2 to 3 days and then go home. Severe symptomatic aortic stenosis is a very bad condition, and it's the aortic valve, the valve at the top of your heart, and it gets calcium on and gets narrowed, and as we get older it calcifies up and gets smaller and smaller and smaller, and the blood can't get out, and people get short of breath, they get chest pain, they can even black out, and if you get to that stage, it's actually worse than having lung cancer. If we don't do something, it's a mechanical problem. If we don't do something, then you're going to die from your aortic stenosis. If you're a young, healthy person, you have an open operation where we have a big operation and we split the chest open and replace the valve. If you're elderly, that involves significant risk, particularly if you're over 80. So this technology was invented in Europe about 10 years ago for people who aren't suitable for open surgery. And currently, if you're over 80, you're high risk, and that's what happens here in Australia now. So we have what's called a multidisciplinary team meeting, which is called the MDT. We gather all the patient's information, their history, their outlook, their age, and the three of us, an intensive care doctor, a cardiac thoracic surgeon, and myself, the operator, we have a meeting, and if we feel they're too high risk for an open operation, then they get a TAVR. Well, what happens is the patients get referred to me either from other cardiologists or general practitioners. They've had an ultrasound, we know they've got severe aortic stenosis, they have a bit of a workup, which involves CT scans, angiograms, ultrasounds, review by a geriatrician, and once they're deemed suitable, then we admit them the day before, and then down they come to the cardiac catheter lab, which you can see is behind you here. The patient's awake, they'll have some sedation, and then we do all the prepping and then get access via what's called the femoral artery, and after a lot of manipulation we pass this valve across their own aortic valve, and it opens up a bit like an umbrella. We pull the sheath back and the valve opens up. Patient's wide awake. It's a bit like having a bit of sedation if you have Not as much as a colonoscopy or a gastroscopy, but they're awake and talking. They won't remember much about it, but it's a lot safer when the patients are awake. They won't remember much. They may have a bit of a sore groin where we put the tube in. They have a bit of a sleep overnight, but often the next day when they get up and walk around, they can walk around the corridor, and sometimes the result's been nothing short of miraculous, where they go for a walk down the hall and back and say, crikey, I couldn't do that on Tuesday. I feel really good. So it's a remarkable change of events for patients.
So this is a percutaneous procedure we're doing, and we need to see where we're going, where we're going to put the valve, and then check that it's working afterwards. So we've got two ways of doing that. We use the fluoroscopy, so the X-ray machinery that does most of the work, guides us up to where we're going. We also have the ultrasound machine, and that's doing a few things, helps us find the vessels we're going into, but that gives us real-time view once we've deployed the valve of how it's working, whether there's any leaks, whether we need to adjust it. So with the fluoroscopy, the X-ray, it's put up within the theatre, and then there's radiologists looking at it outside as well in the control room. So there's groups of people looking at the same images put up on different screens. I think what we need to get an idea of people who are seeing how we do it is to see the number of people involved. So it's not just here with the patient, but it's also out in the control room as well, because there's a lot of people monitoring the patient while we're doing it, including an anaesthetist as well. So we've got the anaesthetic people at the top who are sedating the patient, and then if there's problems, they've got to help with the blood pressure, and if there's bleeding or some other problem, we need to put the patient asleep there or there for that side of it. Well, there's one surgeon, that's me, and then there's an interventional cardiologist, and then my surgical team, who include a heart-lung machine specialist, my surgical nurses and my assistant. This is a lot more expensive, there's a lot more people involved with this as opposed to a surgical team. The payoff for that is the patient's out in a couple of days as opposed to a long recovery. So it's a lot more intensive doing the TAVI procedure at the time, a lot more costs, but the benefits are for the patient, especially our older, sicker patients. At the moment it's approved for high risk patients, but eventually it'll come and it'll be for low risk patients as well.
So this is the ProGlide. Okay, a lot of pushing now. It's good. Well, we're just going to get all these big tubes in to get this valve in there. Let's just try the 10.
Yep. So
just see how it goes, yeah.
Deploy that, we're trying to pass it.
Just see
A series of bigger and bigger cannulas. Now up the vein.
I'll fluoro for you if you like. Bring the C-arm down. We don't want to paste the leg, so we'll just can't twist it. Might just keep pushing it. May
just go on. I've got it up, haven't I?
Pelvic veins. Yeah. Take it down, see if you can rotate it.
Where's that going?
It's up a different one. Yeah, push down. Yeah, got it. There you go.
Oh, yeah.
Yeah, well done. Try the wire up, balloon up, try that. No, it's good.
I thought it was up.
No, I just took it down so we could, there you go.
Oh.
Yeah, beauty. It might be alright, Ben.
You think?
Yeah, just give it a bit more of a push. Just try that. We'll hook that up, Jason, and see what we got. I'm not sure where that is.
So this is an artificial
It's not near around.
pacemaker. So we can control the heart.
Pace it, say 80 or something, just see if that's... Oh yeah, alright, just test the thresholds there. Yep.
So we can
Mate,
pace
looking
the
good.
heart quickly when we're doing it.
Pigtails,
procedure. And also sometimes the patients get heart block after the valve goes in, so
Lovely.
this is to protect
Right.
afterwards as well. The bottom of the valve sits.
Very funny angle, but there you go. Ready, Kev? Okay, set up picture coming up.
So we're going to inject some dye into that catheter. Show us exactly
Right to go, 10 to 10. Yep.
where the bottom of the valve is.
Okay, off you go. It's good. All right, that looks good. Oh, now let's just take this out while we get the big sheath in, hey?
16
All the
French.
pushing and shoving coming up. Are you ready? Good. Give us a few seconds.
So you can see the size of this
16 French sheath. Yep.
canyon, very big.
Righto, you ready, Joy? Take a big breath in. Hold it there. Yep, hold that breath, hold that breath, hold that breath. Now breathe away. It's Heparin, thanks.
Going to use. So now we're just waiting for the valve delivery system with the valve in it to be put together, and then we'll check on X-ray that it's been inserted into its delivery system correctly. And we confirm that by X-raying the whole system.
You can see the LBOT calcium there, right
in the
middle of it.
Yep, it's good. So the valve's at the tip of the system.
1 to 2.
And now use X-ray to make sure it's all straight. And we're just going to turn
Oh,
it.
looks good there. Beauty.
Looks all aligned.
Thanks.
Beautiful.
Just park that there. Okay, now, Joy, a lot of pushing and pulling. Don't move, all right?
And now we're going to put the delivery system over the wire. And guys, holding the artery shut.
Try.
Trying to.
Yep, hold on. Finger on the dike. So just that's it. Yep, it's good. A lot of push. Yeah, you're good. Just don't wriggle. A lot of pushing here. Big. You're doing. Oh, that's really good. Yeah, laughing.
So the previous cannula dilated the artery so we could get this up, which is the valve in its delivery system. Got it.
Okay, just let it settle there. Let's get the. That's it. Actually, we've got a bit of MAR there, haven't we? Just go back to our first picture there. Yes, that's that. We've got to be opposite that bar of calcium. So
Okay.
release, turn,
Opening up the valve, turn.
turn, 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 and stop there. Gee, wouldn't mind getting this bloody catheter back down there. Oh, there we are.
Perfect.
That's better. Okay, that's where I want it. Okay. Righto. Okay, we're going to pace in a minute, Jace, 120. Okay, turn, Ben.
Turning,
So we're deploying the valve now, slowly.
turning.
Okay, I'm just having a little bit of tension there. Yep, turn. 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 And pacing now, Jace. Just wait, Ben. Little puff there, Keb. Good, Ben, off you go. Yep,
The valve's starting
Yep.
to flower open.
yep, test.
Pacing
That's perfect, yep, good.
Okay.
Turn.
Slowly turning the valve. It's opening up.
Yep, it's good. Turn. Slow.
Slowly
Slow.
opening the valve.
Okay, that's good. All the way through. Stop pacing. All the way through.
And
Good,
valve.
that's huge.
80% deployed.
A little picture there, Kev.
Pacing stopped. Blood pressure's good.
Well, that's good.
The valve looks pretty
About
good.
3 mils. We've got a lot of parallax there, haven't we?
Mm.
So we can take that out. Pressure's good.
So we've got to use the X-ray in a different position to line up the valve.
No dye, just have a look at that. Bit more.
Yeah.
That's good. Okay, so a little picture, Kev. Ready? A little bit deeper, isn't it? Not too bad though, about 4, 5. We're going to do one recapture and come back 2 mils.
Pacing on,
yep.
going backwards. Recapturing the valve.
Recapture, recapture,
Turn.
turn. Don't move, Joy. Keep going, keep going. Keep going. Keep going, okay, keep going. Okay, okay, so slowly release now.
Opening. Turning.
Don't move, Joy. Yeah, open.
Turning. 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 That looks good, guy. Turning. 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 Let's touch the side.
Turning, pacing off. That a little break there. Little pup
80%
there.
open.
Kev, you ready?
Pacing off.
Yep.
The pressure's back up.
Yeah, that's better. It's come up about 3 mils.
So that's sitting higher.
No, no. That's much better. That's really good. All right, let's just let that timer on, please, Kerry. Joe, can you have a look, please, Mitch?
So this is a recapturable system.
Yeah, but that's much better position. Yeah, that's good.
Turning. Releasing the system. Forward pressure.
Yeah, it's good.
Releasing. Releasing.
Ka-ching.
Both
Oh,
are
that's
off.
nice. That has come up nicely, hasn't it? And it's dived a little bit. That's really good, James. Delivery system here. The valve's been expanded. It's in place. It was fairly straightforward. A little bit of manipulation. Gee, it's huge, isn't it? The 34 is a big valve, isn't it? There's no question about it. Perfect. Great.
Okay.
Okay, here we come. So a lot of pushing here in the groin. No wriggling, Joy.
Pulling the system out. Keeping the wire in the heart. So guys controlling the
Groin
so
here.
it doesn't
I hope.
bleed.
And kaboomba, we're out.
And we're out.
And let's, yep. That's a shot. So Kev, we'll get this out, and then can I have the short J, Kev?
Yeah.
Yep. I can't see, is it quite symmetrical? It doesn't leak at all. Just trivial. Done. That's okay, that's all we need, Mitch. There we are. Okay, that's good. Out you come with that, Kev. Yep, computer's out. Flush on there, Ben. Great.
So the two
Yeah,
pressures
yeah.
are
I didn't believe. I'm not sure what was going on there. So there's zero gradient. Diastolic pressure is good. There's good separation.
So ejecting dye above the valve.
Hang on, Kev. We'll just see if that looks all right.
Confirm position. Expansion of the valve.
Take that one out. Rightio. Can just have the J wire there, Kev. Thanks, mate.
So putting a smaller cannula back in.
Yeah, we nearly forgot, didn't we?
Now we'll
Right out this one here.
half close up the hole.
Okay, how's that, Ben? You can let go? That's
Looks good.
Looked like there was a bit of AR on the LV-gram, aortogram there.
So we're left with a small hole in the femoral artery this side.
On the mitral side, yeah. Does the MR look as bad?
And
Sorry.
This device on it.
You can just grab the wire there, yeah, thanks.
We'll complete the sealing.
Protamine in? Yep. Thank you. So we're just closing up the other groin now with a little plug. Joy, we're finished. Yep. All done, Joy. Yeah, we're finished. New valves in. So that's the part of most of the work. So have a nice rest tonight.
Stop. Okay. Okay, good. Rightio, we're done. Okay, the wire's in position. So the grind's all sealed, no leaking. Thanks to all those devices we use, and this pacing lead will stay in overnight. The conduction stays good, and she won't need a pacemaker. Thanks, mate.
Okay.
We're all done, everything's good. Good result.
I would just say that if you have an elderly patient who's getting short of breath, make sure that you have a listen to their chest. You may not hear a murmur, but if they're getting short of breath and you think, what's going on here, get an ultrasound, that's an echocardiogram. And if they have a degree of aortic stenosis, get them to come and see me. They may not need a TAVR right here and now. They may in a few years' time, but if they're in the system, they know about it. And if it's needed, then we can get it organised.
We did 2 deployments of the valve, the second just to get it in its slightly higher position so there was less leaking around the valve, and we've got a really good result. We've got no gradient across the valve, so it's opening up perfectly, and there's very little leak around the valve. We were a bit worried because there's a lot of calcium at the bottom of the valve that it wouldn't seal properly, but we've got a really good result. And the valve will keep expanding for another 24 hours, so tomorrow morning our leak will be even better. We'll keep her in ICU overnight just to make sure she's stable. If her electrical system's good, we'll pull a pacing wire out. We'll have her out for breakfast tomorrow morning and probably home the day after. And at this stage that looks like a really good result. So she'll be back doing most things in a few days now.
Joy went extremely well, yes. There are obviously complications with this procedure. With Joy, she went beautifully. She seemed to have the right level of anaesthesia, which again is a good anaesthetist. The team are very experienced. We've been doing this since August 2016. So we've got 4 years down, 250 patients, so you've got a really well-versed team that can cope with complications that arise, but we didn't have to today. It all went beautifully.
Flynn TAVI team, 250! Yeah!